Hi, I'm Jim Treat. I'm a pediatric dermatologist, and I'm here to give you a few highlights of a recent talk I gave on atopic dermatitis, talk a little bit about the management and what to look for in the future. What we know now is that atopic dermatitis is much more associated with negative behavioral effects on children than we've known in the past. And so there's a higher rate of behavioral health issues in children who are chronically itchy. And if you've ever had an itchy child, or if you've ever been itchy yourself, if you can imagine being itchy for most of your time, it makes it so that it's very hard to do all the other activities in life. And so recent studies showed 60% of patients have sleeping difficulties and difficulties with social activities and behavioral issues. And then children with atopic dermatitis can have lower school performance. So it's really important that we treat atopic dermatitis in order to make kids feel as much better as possible. And so we have to balance the risks of the medications, but also with the extreme benefit that we get by making people's eczema feel a lot better. I'm going to use the term eczema and atopic dermatitis interchangeably because it's harder to say atopic dermatitis over and over, and they are similar terms. So there was a nice study put out recently that showed that we may be able to prevent children from getting atopic dermatitis. So eczema is known as a barrier problem, where essentially you don't have the same amount of cholesterols and other protective lipid barrier in your skin as you do if you don't have eczema. And when that lipid barrier is disrupted, the world of allergens and irritants can get into your skin more easily. Then your body overreacts to them and you create a huge inflammatory response. And so what you can see is that on the right, a child who has their lipid barrier protected or their lipid barrier intact, the allergens are sitting on the outside and they don't get to see the immune system. And so they don't get to overreact, and essentially the body doesn't create the same inflammatory cascade. So there was a recent study that was put together which showed that if you took children who were at high risk for atopic dermatitis, so they had siblings with atopic dermatitis or a high rate of atopy in the family, and you essentially started an emollient moisturizer along with gentle soaps within the first few weeks of life, that essentially the rate of atopic dermatitis development was much lower than you would have predicted in the control group. So the control group had 43% of the patients get eczema by the age of 6 months, whereas the therapeutic group only had 22%. Steroids are our mainline treatment for eczema, but again, if we could prevent eczema with just doing thick emollients, the thick emollients are the baseline of all therapy with eczema, and we want to moisturize people within a minute or two of getting out of the bathtub, and then one extra time a day, and make sure that their skin does not dry out. But once the inflammatory cascade starts, it's reasonable to use topical steroids, and it's important to know that there are a million topical steroids out there, and there are many, and so because of that, it can be hard to memorize which ones are the easiest to use. The reality is that lots of different insurance companies cover different topical steroids, but these are some of the ones that we most commonly use. So hydrocortisone 2.5% ointment is a weak topical steroid that can be used in sensitive skin areas. Triamcinolone 0.025% ointment is a middle or low medium potency topical steroid, and then triamcinolone is a medium to medium strong topical steroid. I always use ointments if possible because they burn less and they have fewer ingredients, and so children are more compliant with them. And generally with steroids, what you want to do is you want to use them for short periods of time. So you use them in bursts for 1 to 3 weeks in order to get people better, and then once they have gotten a lot of improvement, you want to switch over to maintenance therapy. So what is maintenance therapy? For most patients, it ends up being just moisturizing and using gentle soaps. But for people who need more of that chronic maintenance of the inflammatory cascade, we end up using topical steroids or their similar medications such as topical calcineurin inhibitors, essentially a couple times a week in order to maintain the benefit. And if they really have severe atopic dermatitis, you end up needing to use topical steroids at a higher potency a couple times a week, but that's where they should be managed by someone who takes care of a lot of atopic dermatitis to make sure that's done safely. Bottom line is you need to find the smallest amount you need to prevent flares, but you also do want to prevent the flares so that children aren't going up and down all the time, because that leads to more chronic use of medicine. There is a huge future to atopic dermatitis, and this is a small list from 2017 showing the medications which are in trials for skin disease. And so now that there's an understanding of the inflammatory cascade, they can pick out different markers in there and block them, and that is going to lead to much better therapeutics in the future. And hopefully in the future we will have more targeted and individualized medicine to be able to offer. Thank you. That concludes my brief overview of atopic dermatitis.